let's get into it today. So let's start talking a little bit about alkalosis. Um, alkalosis, one of the most common causes of alkalosis on the respiratory side is going to be hyperventilation, right? Um, so there's lots of reasons why you might hyperventilate. You might be having a panic attack, an anxiety attack. What's the term hysteria mean? It actually stems from like early days of like psychology and neurology, and it's kind of misogynistic actually. If somebody's hysterical, that means that they're acting womanly because women have, right? When you think about hysterectomy, what does that mean? You're removing the uterus and all that. And so it was thought back in those days that women were the ones that had more like, irate behaviors. Maybe they're kind of like going crazy. So its roots are kind of misogynistic. So we still use the term, right? So-and-so is being hysterical, right? Or mass hysteria. That means like everyone's going into a frenzy, right? So, the connotations are still there. But, in my opinion, men can also be irate and erratic and hysterical too. So it's not just women, in my opinion, but that's from my personal experience. Hypermetabolic state. So your metabolism is increased. What's a byproduct of if you have a hypometabolic state, or for example, if you have anoxia, what's going to be a byproduct of that? Yeah, lactic acid buildup would be an example of like, if you have not enough oxygen, but if you're hypermetabolic, then you're not producing as much of that lactic acid, and so your pH is going to be going in the more alkalotic side. Fever, anemia, and thyrotoxicosis, those are all things that can also result in alkalosis. But mostly focus on ventilation, because that's going to be the most important when it comes to respiratory alkalosis. Metabolic side, there's a couple different things that can cause that, but whenever you lose acids, that's going to, of course, result in alkalosis. You're going to become more alkalotic, more basic. So vomiting, what's in your stomach? Hydrochloric acid, right? If you're puking your guts out, you're losing a bunch of your hydrochloric acid, and that's going to throw your acid-base balance off. You're going to become more alkalotic because you're losing all those protons. Same thing with gastric suctioning, right? Similar type of mechanism, right? You're removing the hydrochloric acid, and now the person's going to become more alkalotic as a consequence. If you're taking antacids, so calcium bicarbonate, right? That bicarb is negatively charged, right? It's basic, and so it's going to create an alkalotic state in the person. So antacid use can result in alkalosis. Diuretics, right? Because a lot of our protons are being lost at the level of the nephrons. And so if you're losing things like protons, you're going to become more alkalotic. And then remember, when we went to this one slide over here, I want you to always associate potassium and calcium. If it's elevated, I want you to think of acidosis. If it's reduced, I want you to think alkalosis. So same thing over here. If you're hypokalemic, so if you're taking drugs like spironolactone, which is a potassium, that is not a potassium sparing, sorry, erase that. That would be more along the lines of furosemide or Lasix. So spironolactone is actually a potassium sparing diuretic. So actually remove that from there. So spironolactone would be the opposite. It would cause increased amounts of potassium in the blood. So yeah, that's not a good example. So furosemide or Lasix, that would be a better example of something that would cause alkalosis because you're losing a lot of your potassium. So this is what's going on at the levels of your stomach, right? So here is the lumen of the gastric gland, and here's the interstitial fluids. So this is what's going on within the parietal cell. This is how hydrochloric acid is being produced at the parietal cells. So you have hydrochloric acid. It's going to be derived from your carbon dioxide and water. Then you get carbonic acid. From that carbonic acid, that's where you're able to disassociate bicarb from the proton, right, the hydrogen ion. And so bicarb is going to enter into the bloodstream, and hydrogen protons are going to enter eventually into the stomach, right? Into the lumen of the stomach. Chloride is going to follow with hydrogen, right? So that's why you have HCl. Hydrochloric acid is what allows for the production of acids within your stomach for digestion, chemical digestion. So this is kind of like the underlying mechanism of how that hydrochloric acid is actually produced. So if you lose a bunch of your hydrochloric acid, you're going to be trying to produce more hydrochloric acid to make up for it. You're going to get more bicarbonate entering into your bloodstream, and you're going to keep on losing hydrochloric acid due to like vomiting, for example, or like suctioning and whatnot. So this is how you can become alkalotic by losing your protons, losing your hydrogens. You're getting excessive amounts of bicarb being produced as a consequence. It's because your parietal cells are trying to make hydrochloric acid so it can digest foods. So with metabolic alkalosis, that's where you see it's mostly mediated by bicarbonate. Remember, respiratory, it's going to be your partial pressure of carbon dioxide. When it comes to the metabolic side, that's going to be bicarb. That's the most important thing. If you see increased bicarb production, that's going to increase the overall pH, right? And so if you lose your acids, then you're going to, by necessity, increase your amounts of bicarbonate as a consequence. Now, compensatory mechanism, right? Because your body's going to try to maintain homeostasis. You're not going to remain in an acidotic or an alkalotic state forever. Because remember, if it gets too high or too low in terms of pH, incompatible with life, right? So you want to stay alive. So your different areas of your body are going to try to compensate for that. So if you are undergoing metabolic alkalosis, what's going to happen? Your lungs are going to try to take over. Your lungs are now going to start hypoventilating because if you're alkalotic, you want to maintain your carbon dioxide levels, right? Hypoventilation is the way you do that. You slow down your breathing and carbon dioxide slowly accumulates to become a little bit hypercapnic. And because of that, that's going to help to balance out the pH levels. You have a question? Someone's vomiting a lot? If you're vomiting a lot and you're losing acids, I imagine if you tell the person to breathe slower, I don't know if that would be enough. I mean, if you're vomiting a lot, you want to do a lot of things, right? You want to replenish your fluids, right? So you want to rehydrate the person. You want to put them probably in an IV. You want to give them maybe, something like, Zofran. You want to prevent them from throwing up. Right? So Zofran is a really good way to do that. So there's a lot of other things you need to be thinking about as well. Maintaining their blood pressure with proper hydration. So, yeah. You could, I guess, tell them to breathe slower, but they're probably going to do that just by default. Their body is probably going to do that automatically because these are all going to be automatic compensatory mechanisms. They're beyond their control. I'll show you what that looks like when you look at Kussmaul's breathing when a person is having diabetic ketoacidosis. So those are things that they're going to have these rapid, shallow breaths, right? Because they're trying to breathe off carbon dioxide so they can bring the acidity of their blood down, right? By losing carbon dioxide. So that's just something that happens naturally. The body's already going to be doing that. Don't tell them to breathe too slowly because all of a sudden they might stop breathing altogether and die. So I don't know. That doesn't really answer your question very well, does it? It's a good thought, though, what to tell the patient. I don't know. Tell them to calm down and stop being so hysterical. Tell them to stop puking. So with compensatory mechanism, hypoventilation, now you start becoming more hypercapnic. Right? That's going to be the respiratory way to maintain the balance. And at the level of the kidneys, too, you're going to see kidneys might be able to start conserving more protons, maybe to start excreting bicarbonate in the urine. I'll show you an image of what that looks like in a second at the level of the nephrons. Respiratory alkalosis, right? That's going to be due to carbon dioxide levels. When carbon dioxide levels are low, because you're breathing off all that extra carbon dioxide, that's going to increase your pH. You're going to become alkalotic as a consequence. Hyperventilation, of course, is going to be one of the major ways you see this happening. Compensation. So to counteract alkalosis, your body's going to try to reduce the amount of bicarb so you can become a little bit more acidotic. So your kidneys could potentially start conserving protons, hydrogen ions. It might start peeing off all that extra bicarb so you can start to reduce your pH a little bit more. That's going to be the compensation. Respiratory alkalosis, these are all the different factors that could come into play. So tachycardia, hyperventilation, of course, is going to be one of the most important mechanisms here. But other things can happen as a consequence. If you are too alkalotic, these are the things that can happen. You can become lightheaded. You could become lethargic and confused. So some of these are going to be symptoms. Some of these are going to be the underlying causes. So nausea and vomiting could be the underlying cause of alkalosis, right? Because you're losing a bunch of your your hydrogen chloride, and so it's going to become more alkalotic. But the big thing here is respiratory, right? So respiratory alkalosis, we're thinking hyperventilation. Cool. So acidosis, a little bit different, but opposites, right? So instead of hyperventilation, hypoventilation. So hypoxemia can cause that, right? So if a person has congestive heart failure, as an example, what side congestive heart failure you would see more hypoxemia? Right or left side of the heart? Left side congestive heart failure. Why? All the fluid starts backing up in the lungs, right? You start getting pulmonary edema. Right? When you get pulmonary edema, then you can't get proper gas exchange, right? And so left-sided congestive heart failure would be one of the main underlying causes. Altitude sickness, you can also see that happening. Lung disease, so COPD, of course, would be an example of that, right? Chronic obstructive pulmonary disease. You'll see things like bronchitis, emphysema as a consequence. Pneumonia, obviously, right? You have an infection, you're going to have a lot of inflammation in the lungs, fluids start accumulating, dead neutrophils start accumulating, forming pus, stuff like that. Asthma, of course, you're going to get like bronchospasms with asthma. You're going to have a little bit of hypoxemia. If you have a broken rib, that can cause hypoxemia as well, right? Because it's so painful to breathe when you have a broken rib. For those of you who have experienced in the hospital, have you worked with anybody with broken ribs? You have? What do you do with a person with broken ribs? Who do you have to have a consultation come in to help the patient? Respiratory therapists. Yes, you have to have a respiratory therapist come in, right? Because they don't want to breathe because it hurts so bad. And you can't really do anything for a broken rib. You have to let it heal on its own. And so you can give them analgesics to help mitigate the pain. But the biggest concern with a person who's not breathing properly is what? This one right here, right? Pneumonia. If a person's not breathing properly, now all of a sudden the bacteria starts accumulating in their lungs, right? It's not getting out of their lungs, and so that can lay grounds for pneumonia. So you want to make sure that the person with broken ribs is able to breathe. So you have to have a respiratory therapist come in and help with that. Drugs, right? We talked about fentanyl overdoses. Any sort of opioid or any sort of central nervous system depressant is going to result in hypoventilation. You're going to breathe much slower, and then you become hypercapnic. Now, the other side of that is metabolic acidosis. Metabolic acidosis, you can get if you have any sort of injury to the heart and you're reducing cardiac output, that can result in acidosis, right? So you start building up carbon dioxide because the blood isn't pumping properly, right? If you're hypovolemic, that can happen. Neurogenic could be can result in acidosis. Anaphylaxis. So these are all different conditions. Sepsis. If you're septic, generally your pH is going to be thrown out of balance. And then these are the other ones that we're going to talk about in more detail. Diabetic ketoacidosis. That's going to be really important. All right, so respiratory acidosis. We already talked about respiratory alkalosis involving carbon dioxide being reduced, but if you're acidotic, you're going to have increased carbon dioxide, so you can become hypercapnic. That's the fancy word for it. And if the pH is less than 7.35, that's when you're considered acidotic. Of course, hypoventilation, then you become hypercapnic as a consequence. And then if your kidneys come into play, what the kidneys are going to try to do is conserve bicarb and get rid of protons. And so this is what's happening at the level of the nephrons. So the nephrons can do a couple things to control for hydrogen and bicarb, right? So remember, with their carbon dioxide and water, with carbonic anhydrase, turns into carbonic acid. And then your kidney could either bring in more carbon dioxide, so it could control the excretion also of protons, right? So it's going to do a little balance with protons, your hydrogen protons, as well as your bicarbonate. And so if you have respiratory acidosis, then your kidney could do more of this. It could try to bring in more bicarb and excrete more protons as a consequence. If you have respiratory alkalosis, then your kidneys are going to try to reduce the amount of bicarb that's being absorbed, and it's going to try to reabsorb more protons to try to compensate for that. So that's what's going on at the level of the kidneys. Metabolic acidosis. So this is where we're going to start getting into like some pretty interesting physiology, because one of the key things that can cause metabolic acidosis would be diabetic ketoacidosis. So we're going to talk about that in a little bit. But if you have metabolic acidosis, you're going to have a loss of bicarb, right? And so what's going to be the compensatory mechanism? You're going to try to decrease your carbon dioxide levels, right? You're going to try to blow off as much carbon dioxide as possible. And this is where you see Kussmaul's breathing come into play. So this is a kid with diabetic ketoacidosis. One second, what's going on here? There we go. This little guy. He got a little bit of a dental abscess. Breathing is really what we're trying to call Kussmaul breathing. When you smell his breath, it makes very sweet, sort of odor to it. So he's getting his getting a little fluid loss, 20 per kilo, and then initial phases. The mom knows his food isn't the one you do, which is okay with that. Right, Mom? Yeah. Okay. Good. Anything else? So basically, last night sugar was 99. Yeah. And when he woke up this morning, he had a little trouble waking him up, and he was breathing. What was he diagnosed with diabetes? Okay, 3 years old. Okay, so he's 5 now. Okay, and this is this the second time you presented with breathing like this, or is you've never seen this before? Okay, so this is the first time. All right. Well, thank you so much for letting us do this. I think this is important for people to see what this Kussmaul type breathing, how someone with diabetic ketoacidosis. Thank you so much. All right, so that's what Kussmaul's breathing looks like. And I misspoke. I said short, shallow breaths. It's short, deep breaths. So it's rapid, and it's going to be deep breaths because they're trying to blow off as much extra carbon dioxide as possible to help bring the pH back to balance. DKA, when a patient is diabetic, has diabetes type 1, generally they don't find out unless they do their blood sugar tests at a young age. But a lot of people with type 1 diabetes, they find out that they have type 1 diabetes by winding up like that. They wind up getting DKA, and all of a sudden they wind up in the hospital, and that's when they get diagnosed with type 1 diabetes. So we'll talk about the mechanisms of all that in a little bit. Why you get that acetone smell has to do with the ketones that are going to be building up. And so ketones, if your cells are starving, are going to be basically an alternative fuel source for parts of your body, like the brain, which really needs a lot of energy. If you have metabolic acidosis, you're going to try to excrete as much protons as possible at the level of the kidney, and you're going to try to bring in as much bicarb as possible. Because remember at the last slide over here, carbonic acid at your nephrons can dissociate into protons and bicarb, right? And so if you have ketoacidosis as an example, then one thing that your kidneys can try to do is bring in more bicarb to increase that pH level. All right, let's talk about the anion gap. The most important anion for the anion gap is going to be this one over here. It's going to be bicarb. Bicarb is an anion, right? It's negatively charged. So there's going to be, for metabolic acidosis, right, you have low pH, right? And you also have, because it's metabolic, you're going to have low carbon dioxide because the lungs aren't directly affected yet, right? The lungs can try to compensate for that. With the metabolic acidosis, you're going to try to breathe off that carbon dioxide, right? But the main thing is going to be bicarb over here. Now, if you have an anion gap, which we'll talk about in more detail, because you're going to learn how to calculate anion gap. It's pretty easy calculation. But these are the types of conditions that result in a low anion gap metabolic acidosis. So diabetic ketoacidosis is going to be one. Lactic acidosis is another. Methanol, salicylates. I have a slide in here that shows you a good mnemonic. It's mud piles. It talks about different things that can cause metabolic acidosis, anion gap metabolic acidosis. So we'll talk about that in a second. Then there's the non-anion gap acidosis. So that's going to be involving chloride ions. So hyperchloremic is going to be one of the major things there. So diarrhea is going to affect your chloride ions. Things like renal failure and renal tubular acidosis are other things involving chloride ions. Now, with this chart, the most important ones, DKA is going to be really important. Methanol and ethanol can both cause anion gap acidosis. Uremia, so if you have any sort of issue with the kidneys and you have all those waste compounds from the kidneys building up, that can result in anion gap acidosis. What else here? So salicylates, that's aspirin type drugs. And then there's other things here too that can result in anion gap acidosis. So aminoglycosides, those are antibiotics that operate on the ribosome. Carbon monoxide poisoning, and then theophylline, which is something that you can use as a bronchodilator. So those different things can also cause anion gap metabolic acidosis. So this over here is the anion gap. Here are your major anions. So you got your bicarb and your chloride ion. The way that you calculate this is you basically take sodium and you subtract the chloride plus the bicarb level. This is normal. If you have anything between 10 to 12, that's going to be normal, right? If you go beyond 12, then that becomes anion gap acidosis. So the gap over here is just basically the unmeasured anions. So normal anion gap, you're going to see a change in the bicarb level, and you'll see a change in bicarb level, for example, with like diarrhea, right? You'd be losing some of the bicarbs, or you might have a renal loss of bicarbs. You can also see that with decreased hydrogen secretion as well. So effectively what's going on with a high anion gap, if you do have an anion gap acidosis, your bicarb is being consumed. Your bicarb is going to be taken up. And these are the major conditions that I want you to remember. DKA is one of the most important ones here, and lactic acidosis is going to be the other one. So this is what's going on with acetones and ketones. So acetyl-CoA is going to be something that's involved in lipid metabolism. So when you're breaking down lipids, you're going to see acetyl-CoA being involved in that process. Acetoacetate and acetone, those are going to be things that you see increased in the metabolic acidosis, for the anion gap metabolic acidosis. In a DKA patient with diabetic ketoacidosis, this is why their breath smells fruity and sweet. It's because they're literally breathing off acetones as a consequence. And the reason why you make ketones to begin with, ketone bodies are going to be something that can be used for energy in the brain, right? And so if you're starving your cells from glucose, which is what you see in insulin-dependent diabetes, aka diabetes type 1, then you're not going to get enough energy from breaking down glucose, right? Because glucose is not able to enter into the cell. And so what does your cell do to be able to compensate for that? You're going to start producing these ketone bodies. And ketone bodies are what can be used as an alternative fuel source. And then whenever you metabolize all those ketones, then that's when you start getting acetones as a consequence. So these are your ketones. These are what will smell kind of sweet in the form of acetone. And so you see ketone bodies building up in diabetic ketoacidosis. That's where the name comes from. Increased amount of ketones. So you get all these different compounds coming out, acetone especially, and that's what smells super fruity. And you get those from from metabolizing fatty acids and during fasting. And people that are on a ketogenic diet, right, they're not consuming carbs, because remember what carbs are, it's a bunch of complex sugars, right? When you break down carbs, you're going to be winding up with more glucose. And glucose is used during respiration, right? When you're during glycolysis, you're breaking down that 6-carbon glucose into 3-carbon pyruvates, and that's going to be used as your energy source. If you don't have glucose, then you're going to have to get energy somewhere else, and so you break down fatty acids, and that's what's going to help to increase the amount of ketones as a consequence so that you can use that as energy. So, in other words, diabetics, they're going to have a lot of keto acids when they break down fats. So, what is something that would help to buffer those protons? What would help to neutralize the the acids? Yeah, bicarb, good. So bicarb is going to help to buffer these protons, right? What's going to happen to bicarb levels if you have ketoacidosis? The bicarb gets consumed, right? So it gets used up. So now you have reduction in your bicarb level. So if you look at this chart over here, that's what's going on over here. So here's your anion gap. If you increase your anion gap, that means that you are losing bicarb, and that bicarb is now being consumed, right? That's the major effect here. That's why we talk about a high anion gap metabolic acidosis. And then what's going to be left behind in terms of anions? Yeah, the chloride ion stays the same, right? So it's not being consumed. What's happening with the anion gap? Going up or down? Yeah, it's elevated. You're getting an increased anion gap. That's the anion gap right there at the top. It's what's not being measured. So if you reduce the amount of bicarb, that means you're increasing your overall anion gap. All right, let's do a little calculation of how to calculate the anion gap. So you have this patient over here, and let's just kind of go through it. So what's going on with their pH? It's low, right? That means what? Acidosis, good. So pH is down, acidosis. Carbon dioxide is also down. Same thing with their bicarb level, also down. They're all pointing in the same direction. So what does that mean? What? It's metabolic because of the M. Is it compensated or uncompensated? It's compensated metabolic acidosis, right? So you know this person has metabolic acidosis. Then you know that. The next thing to do is going to be to calculate the anion gap using this equation, right? So go ahead and do it real quick. First start with the anions. So look at the anions. You're going to look at chloride. So that's 105. Then you can look at bicarb, which is 8. What's 105 plus 8? 113. Now look at their sodium, 138. What's 138 minus 113? I'm not going to try to do it in my head. You can use your calculators. What? 25. Is that an anion gap? What's normal? 10 to 12. Good. So yeah, this person has a high anion gap, metabolic acidosis. So 25 is way above what normal would be. So if it's between 10 to 12, that's normal. If it's above that, then you're thinking the person has an anion gap acidosis. All right, so this is what's going on with glucose, right? So glucose, super important for a lot of things, right? To do normal physiology, normal respiration. Glucose is going to undergo a couple different pathways, right? If you have a lot of glucose, you might start producing glycogen, right? Glycogen is a storage molecule. Store glucose in your store glucose in your liver, in your muscles. So glycogen, highly branched. You break off the branch of that glycogen in glycogenolysis. Then now you increase your glucose levels. And then pyruvic acid, right? So when you break down glucose, which is that 6-carbon sugar, you break it down into 2 3-carbon pyruvates. If you are in an anaerobic state, you get lactic acid production. If you have presence of oxygen, then you get acetyl-CoA, which enters into the Krebs cycle, right? Citric acid cycle. So pretty basic stuff. So what's going to happen in a fasting state? What are you going to see when you're in a fasting state? Are you going to see more glycogenolysis? Are you going to see more glycolysis? Glycolysis, if you're fasting, do you have more glycolysis or less glycolysis? Less, right, exactly. So you're going to get more gluconeogenesis. You're going to get more glycogenolysis, right? You want to produce more, glycogenesis. Did I just say that backwards? You're going to get, if you're fasting, you're going to want to break down glycogen, right, as an energy reserve. So that's some basic stuff there. Now, here's the key with diabetes type 1, right? Because it's insulin dependent. Insulin allows for sugar to be taken up by cells. If you don't have insulin in your body because of destruction of those beta islet cells in your pancreas, you're not going to have insulin, right? In other words, your cells are starving. It's like you're fasting, right? And so if your cells are starving, then you need to get energy somehow. So what's going to happen when you're in a fasting state, you're going to get production of your ketones, right? So you're going to undergo ketogenesis. And so when you have more ketones, your brain is able to survive because your brain can survive on ketones. So that's a good thing, right? That's the most important thing when you have a condition like this, if you're starved with diabetes type 1. So you get increased ketone bodies, but the ketone bodies are also going to be acidic. So if you have more protons, then you're going to be undergoing acidosis as a consequence. And then we talked about the production of acetones as a consequence. That's what gives you that fruity breath. So here's another summary of what the anion gap looks like. So if you have a high anion gap, that's going to be a reduction of bicarb because bicarb is being taken up. Okay, and so you're losing bicarbonate, and so you result in a higher anion gap. So the major ones I want you to focus on, diabetic ketoacidosis as well as lactic acidosis. So, as I said, today's lecture was going to be pretty short, but there's a lot of questions. Now, before we start the questions, if you don't mind, I'm going to run to the restroom. So, there's a lot of questions. So, all right, cool. So let's go ahead and start. So on this, I have 27 questions. So it's a lot of questions. So it should keep us nice and occupied for at least the next, 45 minutes or so. All right, let's go ahead and begin. So the underlying mechanism of type 1 diabetes. So most of you guys got that correct. That's great. So you're not producing enough insulin in your body, right? Your pancreas, those pancreatic islet cells have been wiped out due to an autoimmune condition. Right? That's what results in type 1 diabetes. So you can't produce any more insulin. So now you have insulin-dependent diabetes. You have to take exogenous insulin. Insulin shots, short-acting, long-acting. There's a bunch of different types out there. So yeah, the underlying mechanism, you're starving those cells. Then you get ketone production as a consequence. Was that too quick? I want to put you under pressure. So I can't see it on my. Okay, there we go. All right, so let's do the math real quick. Which ions are we looking for? Chloride ions, bicarb, and then sodium. So let's start with the anions first. So 12 plus 114, 126. And then your sodium is 136. What's 136 minus 126? 10. Is that normal? Yes. All right. Oh, by the way that these questions are going to be structured, there's going to be a lot of distractors. So know what to look for when you see the lab values, because on the exam, there's going to be a bunch of extraneous, unnecessary information that you don't need. You just need to know which things you're trying to calculate for. So ignore everything else here. Just look for sodium, chloride, and bicarb. That's how you answer this type of question. And the math is pretty easy. You should be able to calculate it pretty quick. Not working. Where's the music? Huh? I'm doing this on purpose so I can put you guys under pressure. So I want you to be able to do these quick so you can use your fingers if you have to, point your fingers up in different directions. All right, so let's look at this again. Okay? So what are we looking for when it comes to acidosis? pH. What's the first thing you should look at? Is the pH up or down? It's down. Okay, what's the next thing you should look for? Look for carbon dioxide. That should be the next one. So carbon dioxide, is it up or down? It's normal. Good. So there's only two arrows now. So look at the bicarb. Is it down or up? So it's down bicarb. Okay. So we know it's not respiratory. We know it's metabolic. Is it three arrows or two arrows? It's two. Does that mean is it compensated or uncompensated? Uncompensated. So arrow down, acidosis, uncompensated, right? And it's metabolic. So it's uncompensated metabolic acidosis. All right, so use your fingers when you do these questions. Yeah, uncompensated metabolic acidosis. So start with your pH, then you go to carbon dioxide, then you go to bicarb, and then see which ways they're pointing. If it's two arrows, uncompensated. Three arrows, compensated. If they're pointing in the same direction, it's metabolic. Okay? Did it not? Really? Sorry. Wait, so did you not get a chance to actually see the chart? No? Oh man, so I do need to make these longer. That sucks. All right, so what EKG changes would be seen here? So what are the main ions that you would see affecting the EKG? Two major ones are what? Potassium, and calcium. Okay, cool. So let's see here. We have their potassium and their calcium. What's their potassium here? It's low or high? Low. Okay, cool. Calcium is normal. So if potassium is low, what are you going to see? Blunting of the T wave. You might see a U wave as well. Right? If you had hyperkalemia, then the person would have a spike T wave. So I guess I do need to change the duration of these questions. I'll do that today after we finish today. And so you'll have that as, you can study later on and do these again. But all right, so I made that last one 20 seconds instead of 10, okay? So you have a little bit more time. All right, cool, good. So you guys got that. Let's go over it again. Most of you guys got it correct, some of you guys didn't. So let's go ahead and just do it again. All right, we're doing a lot of these because I want you to be able to do these fast when you get to exam day, okay? So what's the pH? What's the first thing you do? pH. What's the pH? It is high. Good. So fingers up. What's the next thing you look at? CO2. What is it at? It's low. Cool. So now they're opposite. What about your bicarb? It's low, right? So what is that? Is it compensated or uncompensated? It's compensated, and it's opposite, respiratory, and then pH is high, so alkalosis. Good. Awesome. Good job, guys. I'm trying to stress you out, all right? Getting you ready for the weekend. All right, I think you guys are starting to get the hang of it here. So, and plus you didn't have any extra distractors on the chart, so it's pretty straightforward. pH low, so acidosis. Let's see. The bicarb is normal, so it's carbon dioxide, right? Carbon dioxide is high, so you know it's uncompensated respiratory acidosis. So that's a pretty straightforward one. All right, so most of you guys got that correct. Let's do it again together. Okay, so pH, down or up? Down, so acidosis. Carbon dioxide, up. Bicarb, up. So opposites, respiratory. Is it compensated? Yes. So this is compensated respiratory acidosis because your pH is down. Good. Most of you guys got that correct. That's awesome. All right. Let's see here. Okay, most of you guys got that correct. Let's go over it again together. pH, what is it? Acidosis, right? So down. Carbon dioxide, normal. Bicarb, down. So we know that this is a compensated or uncompensated? Uncompensated metabolic or respiratory? Metabolic acidosis. Okay? What's up? Yeah, they should be. Yeah, they should be. You'll be given the normal ranges. So you don't have to memorize all the ranges. Um, yeah. But with the pH, yeah, I mean, you get used to it over time. But for the sake of the exam, yeah, I'll give you the normal range. Even when you do patient charts, even the charts will tell you if it's out of range, right? So pH is what? Up or down? Down. Carbon dioxide, up or down? Down. And then I didn't get a chance to see that. So those are both down. And then the bicarb is down. So what is that? Metabolic, right? Makes an M. Is it compensated or uncompensated? Compensated because you got 3 arrows. And so compensated metabolic acidosis. I'm going to make you bored to death of these types of questions. Just wait. Oh, wow. Okay. So distractors. So there's a lot of distractors in there. So patient 1, that's the first column there. Normal anion gap, right? You see that anion gap is 10, 10, 12 is normal. So pH is up, right? Carbon dioxide is down. And what about their bicarb? Bicarb is, yeah, bicarb is normal. So it's 2 arrows, right? So it's uncompensated respiratory alkalosis, right? Yeah, cool. Let's do a couple more. Are you guys finding these useful? Okay, cool. I spent all day making these yesterday, so. All right, so patient 2, acidotic, right? Carbon dioxide, normal, bicarb, low, right? So this is going to be uncompensated metabolic acidosis, right? Uncompensated metabolic acidosis. Most of you guys got that correct, so good job. Did I word it incorrectly? Patient 3. Oh, what is it? Hold on a second. Uh-oh. Whoops. Let me make a mental note of that to correct that. Dang it, you're right about that. So, like I said, I made these yesterday, so there's going to be some errors. Let me go ahead and correct that just so I know. So that would have been patient 4. So it would have been, give me 2 seconds so I can fix this on my end. So at least you have it on your side later. When you refer back to this, you'll have the right answer, right patient. So patient 3, let's just go through it real quick so I can write the answer for you. So alkalosis, right? Patient 3. Oh, yes, absolutely. So acidosis. Let me fix that. Acidosis. Okay, so they're acidotic. And then what else is going on here? Carbon dioxide is up. And what about their bicarb? The bicarb is elevated as well. So that's going to be compensated respiratory acidosis. Let me fix this. All right, so I just saved it on my end, so when you guys go back to it later, it should be updated. Sorry about that. That's why you need to proofread. Hope I didn't mess this one up too. All right, good. So they're alkalotic, right? The carbon dioxide is elevated, right? So alkalotic, carbon dioxide is up. And what about their bicarb? Bicarb is also up. So that's M, so that's metabolic, right? And it's up pH, that's alkalosis, right? So it's going to be a compensated metabolic alkalosis. Most of you guys got that correct. Changing things up now again. Did that make you guys stressed out? All right, what's the most important ions when you're looking at the ion gap? Let me see what you guys did. Let's see what you guys did here. Oh, damn. All right, that's why we do these, right? All right, so the 3 ions, what's the most important ones? Sodium, bicarb, and chloride, right? So start with chloride and bicarb first. So here's your chloride, 102, 102 plus 20, 122. And then where's your sodium at? Sodium is 140. What's 140 minus 122? 18. So 18, is that high or low or normal? Cool. So yeah, so B would be the answer for that one. That's why we do these. You're going to be masters of these after you're done, okay? All right. Looks like most of you guys got the hang of it. So it's yeah, you guys got it right. Awesome. Easy math, right? So that was patient 3. 101 plus 28 is 129. And then over here, 140 minus 129, 11. 11 is normal. Good. Awesome. Good job, guys. Did I really? Oh, I have to change it to patient 4. Let me make a note of that. I'll change to patient 4. Oh, that's funny. Oh my god. That's hilarious. Okay, sorry about that. Uh, no, this one's gonna be different. You tap on the buttons. This is a brand new feature on quizzes, so hopefully it works well. I gave you extra time. You got 30 seconds for this one. Was that easy to tap on the buttons from your end? It was all right. All right. The first time I started using this new option, so unfortunately, it doesn't give me like your actual score, but I can embarrass you by pointing out exactly who got the wrong answer. You guys look like you did good for the most part, so that's awesome. So, right, he's acidotic, and then let's see, the other values are also off, right? So your PCO2 is low, your bicarb is also low, so that's compensated, and they're going in the same direction. So compensated metabolic acidosis. Okay. So I didn't mean to call out y'all who did the wrong answers and whatnot. So I'll move on to the next question. Oh no. That's funny. All right, so all right, let's look at. Oh yeah. Come on, Trent. I expected more from you. All right, so 7.5. All right, so alkalotic, right? So you start with alkalotic. Let's see, 22. That is normal, and then sorry, no, CO2 is low, and bicarb is also low. So it's compensated, but they're going opposite directions. So respiratory. All right. All right. Let's see how you guys did on this. You got it right. Okay, good. Bravo, Trent. All right, so pH low, acidosis. CO2 is high. Bicarb is normal, so uncompensated respiratory acidosis. So I wish you'd showed me a graph of how you guys did. Whatever. Okay, so pH, high, alkalosis. Let's see, PCO2, normal, bicarb, 39, that's high. So one arrow, right, or two arrows, right? So it's uncompensated. And then because it's involving bicarb, it's metabolic alkalosis. So, are you guys getting the hang of it? Yeah? Okay, cool. There's a few more. I want to do the rest of these today, so we got 6 more questions. So. Got like 2 more of these specific type of questions, and then we'll change it up a little bit. So, zoom view, all right, so let's see here. 6-year-old man in the nursing home, no history other than he's breathing rapidly. What could be going on with this patient now that we're talking about it? Yeah, I think he's got the same thing, compensated metabolic acidosis. What do you think he might have? He's a dude in a nursing home. He starts breathing rapidly. This is a common theme for older people in nursing homes, huh? He might have. He could have that. That could be a thing, but it wouldn't be metabolic, would it be? It would be more respiratory. So UTI. If you have an old person in a nursing home, especially if they're bedridden and they maybe wear diapers, maybe the caretakers aren't changing out their diapers more, maybe they might get a UTI as a consequence. So UTI is a huge thing for older patients. Elderly, altered mental status, you're thinking right away UTI. So you check their CBC, right? So you check leukocyte count, if they have elevated neutrophils. The other thing it could be is stroke. So, God, this happened last year during summer. My dad had a stroke, and he was walking around, and he was very confused, and he had altered mental status. And I had COVID at the time, so I couldn't do anything about it. So I called my mother, so I had her go help him. And so she took him to the ER because I was thinking, Dad has a UTI. That's what I thought. Because he was walking around, altered mental status, middle of the night. He gets to they check everything to do a urinalysis. They do CBC. Everything was fine. Then they did his brain scan, and that's when they found out that he had a stroke. So the first thing you want to think of for an older person is UTI, but you also want to make sure that you rule out things like stroke. So they sent him off to get treated for his stroke. He's still with us today, but he's not doing as great as he was before, unfortunately. All right. What's this condition called? What does she have? Yes, but what does she have? What caused it? Huh? Let's say DKA. Yeah, so she has diabetic ketoacidosis. Um, this is one thing also that's kind of interesting about type 1 diabetics is that with type 1 diabetes, if you don't take insulin, do you lose weight or do you gain weight? If you don't take insulin, you lose weight. Yeah, so what's an issue with maybe like a younger female in her teens? She wants to be thin. She might have diabetes type 1. Do you think she's going to want to take her insulin? Sometimes she will not take her insulin just so she can lose weight. And then she winds up with like DKA, right, in the hospital. So that's one thing to keep in mind. Because what happens when you take in insulin, right? You're bringing glucose to your cells, right? And so when you bring in glucose to your cells, what happens to your adipocytes? They can start creating triglycerides because they have a lot of glucose now, they can start turning that to triglycerides. That means you get increased adipocyte size, right? So more fat cells. So that's a total digression, by the way, but just know that sometimes people do that. If a diabetic type 1 doesn't take their insulin, they'll get skinnier, but not worth it. There's better ways to lose weight. I knew a lady with celiac disease. She would eat gluten just so she would lose weight. Did I do that wrong? Ah, dang it. Okay, let me fix that. Let me fix that on my end real quick. So let's just go through it together then. Okay, so I can fix this for us. So her pH is, where's that? Is low, so she has acidosis. I'm so sorry. So she has acidosis. And then what's amphotericin? Amphotericin B is an antifungal drug. So anti-infiltration B. So she's taking an antifungal drug, and then what's her CO2? CO2 is uh, elevated. No, sorry, it's reduced. Bicarb is also reduced, and her pH is up. So it's uh, compensated respiratory acidosis. What's up? Yeah, so she's acidotic. My God, this is so embarrassing. I need to proofread these later. All right, so let me fix that. All right, so it should be fixed now on my end. So you can get back to it later. I'm gonna start proofreading these. It's 27 questions though. Okay, I wrote them yesterday. Give me some slack. All right, moving on. What's up? It took me longer than 20 seconds. Get out of here, dude. All right, awesome. So compensated metabolic alkalosis. So what's going on over here? He's been puking his guts out, right? So what's he doing? He's losing a lot of his protons, right? So if he's losing his hydrochloric acid, protons, then he's going to become alkalotic as a consequence. What's up? It's well, you have to look at a pH balance on a patient. That's one of the major things you see when you get a CBC and when you do ABGs, where you get the arterial blood gas. So yeah, if a patient has any issue with their lungs or their kidneys, you're going to be looking at their if they're acidotic versus alkalotic, and you want to see if there's any compensatory mechanisms coming into play. So yeah, you do look at this depending on what cases you're looking at, right? So if you're looking at a patient that has pneumonia, or maybe they have like uremia, or maybe they have methanol toxicity, DKA, right? You will be looking at these levels, assessing for that. What's up? 35 and 45. Why is it wrong here? But where's the PCO2? 35, 45, so normal point. Ah, yeah, you just pointed that out. It's good. You're paying attention. Let me fix that question. Yeah, 45 would be on the it's on the high end, okay? It's on the high end. So let me fix that. I'll make it more exaggerated. Let's put it, we'll fix that later. CO2 45 question. Okay. All right, moving on. So you're puking your guts out, right? So if you're vomiting, what's going to happen? You're going to be losing a lot of protons. And then when you're losing a lot of protons, one of the compensatory mechanisms you might see would be increase in bicarb. So at the level of the kidneys especially. What's up? That is, I might have said that. This one right here. Yeah, I might want to rewrite that question then. Let's see. Ah, this one over here, right? No, this is for ketoacidosis. So let's go back to the kidneys. So let's see. If you're losing a lot of protons, your kidneys are going to try to compensate for the loss in protons, right? So you're going to try to reabsorb protons. Let me look at that question. I might want to scratch that, but if it's something that's a little bit too complicated, I won't put that in the exam. So yeah. Yeah, let me go over that. Let me try to fix that, and I'll post like an update in the announcements. Okay, that sound good? What's up? Yeah, when you're vomiting, right, right. So at the level of the GI, the parietal cells, you'll see exchange. So in the parietal cells, you'll have the creation of hydrochloric acid, right? And so one of the ways you get the hydrogen is from carbonic acid. You're breaking down carbonic acid, turns apart into hydrogens, and then you're going to be releasing bicarb, right? And then you're going to be bringing in chloride, and then chloride is going to go along with hydrochloric acid into the inside of the stomach to increase the acidity and decrease the pH. Yeah. Does that kind of answer that question though, with regard to the exchange of bicarb and chloride, so that you're like creating more hydrochloric acid? Let's go back to that just real quick. I may as well go into it. Go back to that one slide. So this is the slide you're talking about, right? So, all right. So this is in your parietal cell. This is where you get hydrochloric acid being produced. Now, the hydrochloric acid is going to be coming, of course, from carbon dioxide and water, so you get carbonic acid, right? And the carbonic acid disassociates. You get the proton entering into the stomach, and then bicarb goes into the interstitial fluid, which eventually winds up into the bloodstream. Then you're exchanging that bicarb for chloride, so chloride is going to be coming in. So if you're vomiting a lot, you're going to be losing hydrogen chloride. But in order to be able to create more hydrogen chloride, because you want to be able, your stomach still wants to produce hydrogen chloride, then it's going to be increasing the uptake of chloride ions in exchange for bicarb. So let me see how that relates to that question if I worded that incorrectly. Let me just double check here. Yeah, so let's go back to the question now. So here's the question. Loss of protons. So you're losing that hydrogen proton, and then you're going to be increasing the bicarbonate in the blood, right? Because you're exchanging bicarb for chloride ions. Does that make sense? Okay, cool. So I'm glad I clarified that now. Thanks for your help. I appreciate it. I had a little mini seizure moment there. Senior moment. All right, we have 2 more. Howdy. So for a question like this, the first thing you want to start off with is look at their pH and what the underlying mechanism is. So if they have, let's look at the questions. I can pull up the options. Dang it. So in the vignette, you have a person with pH 7.23. So what's that? That's acidosis, right? And then you have carbon dioxide is normal, okay? And so their bicarb is what's off. So the bicarb is reduced. So that's going to be a uncompensated acidosis, right? Uncompensated metabolic acidosis. Now, you could proceed to calculate their anion gap. So let's go ahead and do that and to see if it's normal or not. Let's see. So chloride ions, it's 106. Their bicarb is 18. So that's 124. And then you look at their sodium is 135 minus 124. That's going to be 11. So it's within normal limits. So it would be, the option would be A. Oh, uncompensated metabolic acidosis. Gosh. Okay, let me fix that again too. I'm using you as my guinea pigs. I apologize. You guys are doing good. You're doing better than I did when I wrote these. So let me go back and fix that. Let's see. Metabolic acidosis. Normal gap. There we go. C. All right, now it's correct on your guys' end. So go back to it later. Hopefully this next one's correct too. So let me just make sure that the answer was correct on this. I apologize, guys. Like I said, I wrote these yesterday. So, okay, let's just go through it together real quick. So pH is reduced, right? So acidosis. Let's see. Carbon dioxide is also reduced. Bicarb is also reduced. So that's going to be a compensated metabolic acidosis. Then if you calculate the anion gap, so 106 plus 14, that's going to be 120. So 135 minus 120, 15. So that is elevated. So that was correct. It will be the second to last option. Whew, that was a doozy. Thanks for bearing with me. Was it helpful besides those like blunders, the little mistakes there? You got used to it. All right, good. Even you did better than I did, so that's awesome. That's my goal, is to help you guys be awesome. So use those as practice. I fixed them, so they're updated now. So use those as practice, and have a great weekend. See you guys next week.